Yeah, thank you. Thank you. It's really a pleasure to be here. Actually, it's a joy to be here. I see so many colleagues and so many friends and teachers and people whose work I still think of all the time, that it's a great community of investigators. I also want to thank David for a great job in organizing this symposium. And it's just been a wonderful day. But I want to start by saying it's the 50th anniversary of Bill Northway's paper that Phil Sunshine contributed immensely to behind the scenes. But it's more than just the paper. It's about that teamwork, as Pete Morani so nicely said, between disciplines. It's really a whole career as a clinician scientist, where we went bench to bedside and taught so many people and really rigorously set the stage, which built a foundation for clinical care, clinical research, and laboratory science all combined. And that's really remarkable. So I think that's what this 50-year thing is really all about, is to celebrate that. And it's really my pleasure to be here for that. Before speaking, I have to mention I have just some relationships with industry, Shire Pharmaceuticals, United Therapeutics for laboratory support, and then from Mallinckrodt and GlaxoSmithKline and Chiesi for some other advisory or educational funds that I have here. So believe very little of what I say for that reason alone, I guess. What I'd like to do is talk about something a little different, and I always call it the poor cousin of the airway, but the lung circulation. And the developing pulmonary circulation has always been front and center for some of the morbidities and mortality. And it's been there when we first think about BPD from the original paper 50 years ago in other settings, and I'll speak to that. But what I'm going to talk about is the lung circulation more broadly, and really talk about not only the idea of pulmonary hypertension and what it means, but pulmonary vascular disease, and also the role of the endothelial cell in terms of signaling to its neighbors, in terms of influencing how the lung grows and develops. So specifically, I'll discuss the impact of early disruption on vascular growth, on the risk for pulmonary hypertension and severe BPD. We'll highlight how preservation of angiogenesis and what I'll refer to as angiocrine signaling, and that is the release of endothelial-derived products to its neighbors, can influence function and development, and may be a clue to how we can better learn how to prevent BPD. And then finally discuss very briefly the clinical data supporting the role of early identification of at-risk newborns through echocardiograms, as Pete Morani already highlighted, and perhaps some proteomic biomarkers. But I'd like to start by saying bronchopulmonary dysplasia is really a disease that knows no bounds, no boundaries. As you heard from Rob Tepper's talk, it's airways, it's airspace, it's interstitium, it's vessels, it's central airways. And of course, it's still chest wall, Greg, and control of breathing as well. That's very important. But the classic diseases illustrated here could certainly be severe hard-hitting, heterogeneous involvement in lung regions. It leads to what we are targeting now scientifically so much, and that's alveolarization and vascular growth along with that. But again, what I want to emphasize in both our animal models, Rory, but also in terms of what we see clinically, the airway is still vital. And airways reactivity, airflow obstruction is still a major clinical issue we need to better understand. But it's really from the early report from Bill Northway and his colleagues that the early recognition of severe pulmonary hypertension was already front and center in this manuscript. When you look at this phrase here, he says the most advanced lesions of the pulmonary arterioles were in the lungs of a child who had the most severe alveolar growth abnormality. And most of the kids who died had evidence of frank cor pulmonale when they died. The other thing that I like is that he mentions the term pulmonary vascular disease. In other words, it's not just about the idea that we create an afterload for the right ventricle, we create extrapulmonary shunt, but it's actually how the vasculature grows is important for exercise tolerance, for how the airspace grows and other kinds of features. So a lot of the issues were there from the very get-go. What we also know, and Pete showed this slide too, is we still have this problem that late pulmonary hypertension is associated with poor survival in BPD. It's certainly associated with severe BPD, but what's really a little disheartening is that it's about a 50% survival in those who had significant pulmonary hypertension, which is absolutely no different from what was seen in the late 70s and early 80s. Furan and colleagues and Henry Halliday and others were reporting a very similar mortality. if you had pulmonary hypertension beyond 6 months of age, beyond 4 months of age, you had about a 50 or 60% mortality as well. So I think that's sort of the then perspective, and hopefully we'll get to the next shortly. But I wanted to start first by showing you a little bit of data that still highlights how important we think this problem is. And it's a little bit of data from a group we call the Pediatric Pulmonary Hypertension Network. It's a site of PH programs around North America, about 10 sites now. And these are data which simply show the classifications of pulmonary hypertension that were referred to in our databases and registry and were enrolled for study. Since then, we've doubled this population. We have about 1,500 kids, but the proportion remains the same of what I'm about to show you. And that is, we think a lot of pulmonary hypertension and idiopathic forms of disease, and a lot of research goes into it, and certainly the congenital heart disease patients. But when we look at our registry, about 45 to 48% of those infants have group 3 disease, meaning pulmonary hypertension associated with lung disorders, and that the vast majority of these are really constitutive by bronchopulmonary dysplasia and, of course, diaphragmatic hernia. And these are kids, a very highly biased registry in the sense that these are kids who are referred for consultation. Think about all the preemies in your NICUs or other places who have abnormal echoes, never see a cardiologist or someone else beyond the echo, or started on therapy and followed. So I think it's really the tip of the iceberg of how significant the problem of pulmonary vascular disease really is. And I just wanted to show you this to highlight how important we need to think about this as we move forward. The other piece that's kind of fun is a little bit of history, the then. And it's with John Clements and Bill Tooley, the San Francisco group, and Ernie Cotton did some training there in those days, went to Singapore. And it's called the pulmonary hypoperfusion syndrome. And this era was a time when they're trying to sort out the relative merits of giving an exogenous surfactant for the airway side versus giving a pulmonary vasodilator for the vascular side. And so this is sort of the schematic, and it looks like a very early version, an imperfect version of what Roberta so nicely showed previously today, about showing the role of what can cause lung injury, atelectasis, perhaps surfactant dysfunction. But the centerpiece here that's highlighted is pulmonary vasoconstriction. Well, that led Ernie and a number of folks, and in this case, this is Ernie's letter to the editor in Pediatrics. And at the time, he highlighted the use of priscaline for treating PPHN physiology in these preterm or near-term infants. And as Ernie so nicely puts, it's a marvelous drug, it's a miracle. No complications. We've reported no significant deleterious side effects. A pink flush is produced, which I guess is a good thing. No severe GI difficulties. And Ernie was pretty excited, right? And that's what a lot of us trained on priscaline or tolazoline. That was our only choice at the time. So we remember those days. Remember all the GI bleeds, the thrombocytopenia, systemic hypotension, and sudden deaths. So Ernie got an earful. In those days, it wasn't Twitter, it was regular mail, but he still got a ton of those responses. So clearly there is a need to better understand how to treat pulmonary hypertension in the preterm infants with pulmonary hypertension, and also to find a more selective agent that could be used. And over the years, of course, inhaled nitric oxide has been shown, at least in the term infant, be successful for babies who have persistent pulmonary hypertension. The piece, and the reason why I'm showing this slide is it illustrates its use in a preterm infant. And the idea that preterm infants, a subgroup of those babies, can have PPHN type physiology. Extrapulmonary right to left shunt across a duct or a foramen causing profound hypoxemia. Often in the setting is a child that's shown here with relatively oligemic looking chest film. And as shown here, the baby was on that mean airway pressure. Because at the time there was no other therapy that was being applied, they were ramping up the oscillator, mean airway pressure, to sustain oxygenation. But with initiating nitric oxide, this baby shunt became left to right. We were able to drop the mean airway pressure support and sustain oxygenation. And it just is a reminder that the preemie can still have PPHN physiology. And this has been borne out in a number of different case series. Stella Kurumbanis described a series of kids with IUGR and bad pulmonary hypertension, which is very important. Others have shown that in the setting of oligohydramnios or prolonged premature rupture of membrane, those babies seem particularly susceptible to PPHN physiology at birth as contributing to their hypoxemia. And this is one slide that's an example from Finland showing a marked improvement in oxygenation by arterial alveolar ratio or by oxygenation index. This is work that Satya Laxmanursma, it's hard to say that for me, has published. A beautiful paper just came out, and he describes the use of nitric oxide in preemies with pulmonary hypertension. And it reminds us by this histology that these babies very early on could already show hypertensive arterial remodeling as some of the early changes. And he correlated wall thickness in fatal cases with disease severity. And so overall, as a group then, through American Heart, American Thoracic Society, we did make a recommendation when it comes to preemies with pulmonary hypertension. Certainly those with severe hypoxemia, that's primarily due to PPHN physiology, rather than parenchymal lung disease, and especially the story of PPROM or oligo, that these babies may be good candidates for receiving nitric oxide. And I highlight this because I think the message is through the American Academy and others that the failure to show that inhaled NO prevents BPD, consistently at least with all those data, is a different use of a vasodilator than a preemie who has profound hypoxemia and documented PPHN physiology. So I think that's a concept that's very important to think about, but it also reminds us how important the vasculature can be even in our preterm infants. Then finally, I wanted to show this about established BPD, a different kind of baby. And Roberta Ballard's group showed many years ago that with babies who had chronic respiratory failure, giving nitric oxide over a few days, as illustrated here, can often lead to the lowering of FiO2 by better gas exchange through VQ matching. The second feature is that, as shown in the cath lab on the right, is one could see that some of these infants have remarkable reactivity to inhaled NO as well. And so again, we don't have data that suggests we should use nitric oxide routinely in the BPD patient, but it's one of the therapies that's offered in terms of managing overt pulmonary hypertension. Well, that's sort of the then part. I want to get into some of the next part. And the way I view it is sort of shown on this slide here when I think about the components of neonatal pulmonary vascular disease. A lot of what we discussed, and we'll spend a lot of time studying, were the roles of agents that modulate tone and reactivity in the vascular bed, in the fetus and the newborn, in different animal models. And certainly the release of nitric oxide or prostacyclin in terms of vasodilation, endothelin, all of these things from animal models were shown to be important in terms of modulating tone. We know the normal fetus has high myogenic responsiveness. In other words, a little stretch of the vessels and they tend to contract. Goes away in the normal newborn setting, but is sustained in the setting of pulmonary hypertension. And those mechanisms are quite different from what's going on at the endothelial level per se. And they're likely important for some of the pulmonary hypertensive crises that we see in the NICU, the PICU, or other kinds of settings. Certainly acute reactivity testing, the changes with infection, those all speak to reactivity and tone. Remodeling, there could be striking thickening of the smooth muscle, there could be adventitial changes, dramatic changes in the matrix, and certainly growth in terms of vasculogenesis or angiogenesis to provide sufficient surface area. And all of these combine then to elevate pulmonary vascular resistance, and this is often the clinical problem that we face and really is undergoing extensive research to understand these mechanisms. The piece that I think is the next part of this is this concept of angiocrine signaling, and that is the role that the endothelial cell is a factory of all sorts of products that speak to its neighbors. It informs the smooth muscle, it informs the alveolar type 2 cell and epithelial cells, fibroblasts and macrophage, but it's these signals and crosstalk are so important in normal development and likely go awry in models of BPD and may be novel targets for intervention. So when I think about what this means for the lung then, certainly it has something to do with vascular surface area. An autocrine effect of angiogenic factors in terms of growing more vessels is important. Alveolarization, the endothelial cell signaling the epithelial cell or other cells to start to septate and to form new alveoli. And finally, the role in lung regeneration. And we're going to hear from Stella and from Bernard and others about regenerative medicine. But I think a lot of exciting research is showing that the endothelial cell itself plays a role in this mechanism. a lot of the effects of these stem cells and other progenitor cells that are given, exosomes maybe, is to preserve this functionality. And within the vessel wall itself, it probably holds some progenitors that are very important in the lung growth post-injury in terms of repair mechanisms. So for prevention of BPD, some of the key questions, again, different from the therapy of pH, are what are the early prenatal events and related factors that predispose to sequelae in preterm infants? What are the key pathobiologic mechanisms that disrupt normal lung growth and development? Can we identify useful and effective biomarkers that can identify at-risk infants early? And what kind of novel interventions to prevent or restore normal lung growth and function could we come up with from some of these studies? So this goes way back in some of the old study we've done a while ago, but it is how we first started thinking about the role of the endothelial cell beyond pulmonary hypertension alone. That is, we had an animal model, a sheep model, where we closed the ductus arteriosus in utero. This caused PPHN and was a great source of joy to study in the laboratory. But what we ignored for a long time is the lungs for those animals were smaller than the controls. They had lower lung weight to body weight ratios. They had fewer vessels by immunostaining, and they started to show a pattern of this alveolar simplification. Larger distal air spaces, fewer septae. Well, we then went to rodent models and certainly given drugs like fumagillin or thalidomide to inhibit angiogenesis, not only caused pulmonary hypertension, but they caused this alveolar simplification as shown in the lower panels here. And then finally, using a VEGF, vascular endothelial growth factor receptor inhibitor, one can mimic these other changes, but perhaps more selectively. That is, treating pups just a day after birth and watching them grow over 2 weeks. We still had this incredible simplification of the arterial tree as shown here. This co-traveled with fewer alveoli and significant pulmonary hypertension. And indeed, if one follows these rats out, not only through infancy, but into adulthood, we don't see a growth response of recovery. The upper panel shows the infant control and treated pup. The lower is the adult animal. And one could see those brown spots are all vessels filled with barium. You could see that the adult lung, even following this brief exposure to VEGF inhibition, it was sufficient to still impair alveolar growth and structure, along with fewer vessels as illustrated here. So the way we think of this is we've studied many different models, rat models and rat fetal lung explants and cells, and this is just a schematic just to illustrate this overall concept of angiocrine signaling. And for VEGF in particular, which we think is so potent during development, you can see how it acts on the endothelial cell, some cases releasing nitric oxide. In this case, we're interested in another endothelial-derived growth factor named hepatocyte growth factor, or HGF, which then acts on the epithelium to stimulate septation and alveolarization. In this model, or in these species that we studied, VEGF doesn't directly affect the epithelial cell, but it requires co-culture with the endothelium, and it requires a healthy endothelium for these changes to occur. The other part that we've learned from some of our sheep models is the idea that when it comes to regenerative medicine, there are populations within the vascular wall of heterogeneous endothelial cells. And two cell types are those that grow in a normal fashion and those that are highly proliferative. And that's usually in conducting arteries. We haven't explored the alveolar space. But at least two different populations, and certainly in diseases that mimic human disease. In this case, it's diaphragmatic hernia. But we see the same thing with our PPHN sheep model. We lose this population of highly proliferative cells. It's illustrated here on the left. These are single-cell assays, clonogenic assays. And one could see in this 96-well plate that there are far fewer cells in the CDH population that show striking hyperproliferation within the well than what we see in the control. So in other words, exposure to conditions that mimic CDH are sufficient to lose this progenitor-like population from the vessel wall. And we're trying to explore mechanisms to better understand those mechanisms. Well, when we think about pulmonary hypertension and some clues of what's going on, we can go to some clinical data and epidemiologic studies, which have taught us that there are a number of antenatal determinants that really set the stage for both BPD and pulmonary hypertension. And this is from a terrific review that was written looking at some of the risk factors for pulmonary hypertension in infants with BPD. And I show this to highlight a few things. The first is the impactful role of low birth weight and certainly prematurity in terms of developing PH or BPD. The other is the high rate of intrauterine growth restriction, or being SGA or oligohydramnios. And all of these are quite interesting because they speak to the idea that these antenatal determinants change the response at the time of birth and shortly thereafter, that increase risk for neonatal morbidities, but also perhaps for BPD. And one piece of data that I'd like to think about has to do with all these oxygen trials, what to target. And in this case, looking at these data, which suggests that treating with lower oxygen levels may increase mortality in our preemies, one could see clear differentiation of babies who are grown AGA versus those who are SGA. So in other words, the signal that's come out from these multi-center trials and these Cochrane reviews and things like that suggests that we're really talking about a different kind of baby in response to oxygen. And that the impact of lower saturation shortly after birth may be sufficient to raise mortality risk in the SGA infants. And I like this because, again, it really tells us we have to do a better job of phenotyping at-risk infants at birth beyond lumping all of these premature babies together. A lot of questions were here about what to target for oxygenation and what to use for models, and I think part of it starts in utero. And so that led to this idea of antenatal vascular origins of BPD. A lot of this comes from Alan Job's work, where he's pointed out so nicely all the prenatal factors, chorioamnionitis and other stressors that can affect the fetus or the newborn. And also work from Karen Meston from Northwestern, where she's beautifully shown that abnormalities of the placenta structure can predict which babies go on weeks later to develop BPD or BPD with pulmonary hypertension. Now, her group has further shown that there's a change in cord blood biomarkers that simulate a anti-angiogenic environment. That is, there's fewer pro-angiogenic signals like placental growth factor or VEGF, and more anti-angiogenic factors like soluble FLT, a VEGF receptor that has inhibitory effects on VEGF. And these clinical biomarkers were strongly associated with the placental changes and with how the babies did afterwards. And we got excited about that because we think it speaks to this idea that we do set the stage in utero, that BPD, even though we talk about these animal models of hyperoxia, ventilation, many things that we do and how to titrate that, very few of those reviews really discuss antenatal models of disease. And yet to mimic the epidemiology, to mimic some of the clinical cohort studies, I think that might be a rich area for investigation. So taking that as a lead, we developed a couple of these models. One is giving something called S-FLT, which is produced at high levels in women who have preeclampsia. And knowing that preeclampsia is strongly associated with risk for BPD, we simply injected S-FLT into the amniotic sac 2 days before delivery, delivered the pups, and followed them out for a couple of weeks. And as shown here, you can see that their lungs at 2 weeks of age show sustained inhibition of septation and alveolarization. There was increased endothelial cell death or apoptosis early on. And these pups developed pulmonary hypertension during that 2-week time period. So this was exciting to us because it speaks to the fact that antenatal events in the absence of postnatal injury can be sufficient to cause structural changes that mimic BPD. And so we followed this up by using a monoclonal antibody against S-FLT and showed that we could improve lung structure. These are radial alveolar counts that show improvement from the drop seen with S-FLT treatment. This is when we give the moms infusions of the monoclonal antibody. And again, the S-FLT itself is in the amniotic sac. We also show we could prevent pulmonary hypertension as assessed by RVH in this model. So we wanted to look at another antenatal model. In this case, it was trying to mimic chorioamnionitis. We injected endotoxin in lieu of S-FLT and saw very similar kinds of changes that I'll show you. But the interesting thing to me in this model is that inflammation itself induced by endotoxin was sufficient to upregulate S-FLT, both in the tracheal lavage fluid as well as the serum of these pups who saw endotoxin. And certainly in this model as well, the same kind of findings. Improved lung structure as shown here, And the prevention of pulmonary hypertension is shown on this slide here. And then finally, just one other approach that we've used, because it may become clinically relevant more quickly, is this idea that one of the angiocrine factors from the endothelium is insulin-like growth factor 1. Now, this is data that's from human pregnancies, and this is from Ann Hellstrom's work, and Ann worked with Lois Smith, and they developed concepts regarding another vascular bed, the eye or the retina, and they showed that VEGF acts in part through IGF, that early preservation of IGF signaling in the eye is protective from hyperoxic injury, and from these clinical data showing how preemies, for weeks after they're born, have very low levels of circulating IGF. So their study then was to look at the idea that IGF may play a role in preventing ROP. We were interested initially in simply looking at our animal model and what it does with angiocrine signaling. So we took our 2 models of chorioamnionitis and preeclampsia, where there's impaired VEGF signaling, and initially gave IGF back as a downstream mediator to see if we could correct the lung abnormalities. And sure enough, IGF treatment postnatally improved lung structure as shown here and prevented pulmonary hypertension. We also see the vascular bed by this barium CT shows striking improvement or near normalization after receiving IGF. And then finally, these are exciting to us because when Ann and Lois looked at their clinical data, they were disappointed because IGF treatment didn't prevent ROP, but we were excited because it caused a remarkable reduction in the severity of BPD. It's only 120 patients. It's only been presented as abstract form, is now being written up, but one could see already striking differences in this population, suggesting a promising approach, perhaps, for disease prevention. Then finally, the clinical questions to relate to this is, does evidence of early pulmonary vascular disease predict the risk for BPD in preterm infants? Pete Marani already went through our clinical trial design, and I won't repeat that, showing how some changes in the echo were predictive. I simply want to show some data briefly about the proteomic part of the study, in which we drew blood samples at day 7 of postnatal life and correlated these assays done by SOMAmer methodologies. And this is a simple way of looking at 1,200 peptides from just 50 lambda of blood, so it's pretty remarkable. And we're excited because we could find signals that are related to angiogenesis that are both increased or decreased, but are strongly associated with risk for BPD. And I'm especially excited, and I think Karen will like this, because 3 of the strongest signals are exactly what Karen found in her cord blood studies with the placental abnormalities. Now, these are samples not from cord blood from day 7, but show that increased VEGF, in this case SR3, decreased placental growth factor and a form of VEGF, all co-travel with high risk for BPD. So finally, we'd like to somehow find a better way of resolving pulmonary hypertension and BPD and perhaps preventing disease. And we're already starting to see this turn the tide, as shown by one of these series from South Korea, in which they show a remarkable decrease in mortality compared to the high-risk historical groups. And so we hope that with more knowledge and information, we could better be informed about how to treat and manage these infants. So in conclusion, we know that endothelial-derived angiocrine signaling preserves normal lung vascular and alveolar growth. Early signs by echo of pulmonary hypertension or proteomic biomarkers may be useful for identifying at-risk kids. And strategies that enhance endothelial function and angiocrine signaling perhaps may improve long-term outcomes in these babies. So I'd like to thank folks. You heard from Chris and from Pete Marani, who are shown here, but John Kinsella and Dunbar Ivy from cardiology, a terrific lab group. These are the surgery residents, Brad Wallace and Christine Kim, who did all the IGF and S-FLIT work, and then my 2 PRAs, Taylor and Greg, and they've been fantastic to work with. And then finally, the folks from PPHNet, including Jeff Feinstein from Stanford here. Thanks for your attention.